So what we are going to see about mm, that is the nausea and vomiting during the early pregnancy, and then we are seeing the non-obstetric causes. So what may be the cause? It can be, it may be something appendicitis, it may be due to something cholecystitis, and the pancreatitis or the hepatitis. Now, how we are going to clinically differentiate between the vomiting due to the obstetric cause and vomiting due to the non-obstetric cause? Simple basic anatomy that you know it, where the appendix it is situated. Hello, where the appendix anatomical site, because this is going to be helpful for you to differentiate between the this related with that of obstetric cause or this is related with the surgical cause. Appendicitis, but obviously it is related with that of surgical cause. And as we know that in appendicitis, whatever the pain, it is in the right, that is called McBurney point. Where is the McBurney point? It is related with that of line between the umbilical to that of the anterior superior iliac spine, medially two-thirds. That is the characteristic of appendicitis pain. Such type of pain you are not going to see in the obstetric cause. Fine. Second thing in appendicitis, if you do the Soha sign or obturator sign, what is this sign that when you hit your right leg to the laterally, there is a pressure on the muscle and it just irritates whatever that appendix and it leads to some pain. That's what is called as an obturator sign. And that can use that use something that is indicates this is related with that of appendicitis. Such signs are absent when there is a nausea and vomiting due to that of obstetric cause. Next one is that is related with cholecystitis and pancreatitis and hepatitis. In pancreatitis, whatever the pain, it is related to the epigastric region. What is the reason behind it? In because pancreas location, anatomical location, it is there. The pain is going to be there. While in hepatitis, what we are going to, there is a presence of icterus additionally, which is not present in cases where there is a simple nausea and vomiting. So that basic knowledge that you should have it, that is how you are going to differentiate between that of nausea and vomiting of normal pregnancy that is related with that of and that of non-obstetric cause. Simple logic that what we are thinking about is gastroenteritis, but obvious what is the additional symptoms we are going to say? It is the gastroenteritis. So that is related of the problems related with that of stool, that what we are going to say is or problems related with that of some nausea vomiting is common, but there's bowels, there is frequency of bowels is going to be there. So that is going to be present. Then intestinal obstruction and the chronic infection with the Helicobacter pylori. So infection is there, sometimes there is a fever is there. So that's how you have to differentiate between the normal nausea vomiting during the pregnancy and but obvious that is related with that of surgical causes that what we have seen. Mind don't think always that nausea and vomiting in pregnancy it is only obstetric cause. It has other causes. And being a physician, being a clinician, you should have this basic concepts. Then okay, the whatever the other causes, something it may be that of non-obstetric causes includes endocrine problems. What is the sometimes ketoacidosis is there or thyrotoxicosis is there. In that thyrotoxicosis, you know that whatever the eyes of that patient, it looks like that of protruding. And that thyroid means that how can you clinically differentiate between the thyrotoxicosis and that of the non. In the normal pregnant lady, the eyes are at the level of normal level. While in thyrotoxicosis, the female is pregnant. But what is additional? What we are saying is the eyeballs are like that of protruding. So that we can think about it. That is related with that of thyrotoxicosis. Or sometimes there is a pyelonephritis. So, but obvious that is related with the symptoms of the kidney that we are going to see it. or sometimes there is cerebral tumor. In cerebral tumors, the patient may having the symptoms of this, like that of the headache is going to be there, or tumor sometimes. The patient, whatever the pathology related to that of the tumor, it is going to be there. Or sometimes there is infectious fever. Infectious fever is also there. In normal pregnancy, we don't have that fever in the female pregnant lady. While in case of infectious fevers, there is a fever associated or other infection signs that is going to be there. Body is going to be there. All the symptoms are going to be there. And the red degeneration is a fibroid with pregnancy. What is red degeneration? You know it. Fibroid. What is fibroid? It is the benign growth. And what is red degeneration? Red degeneration, it is the whatever, if you fibroid, if it is not treated in the timely, it leads to the further pathology. And if that red degeneration in the fibroid, along with the combination of pregnancy, see, what is the scenario over here? It is the uterus with that of fibroid, which is not treated properly, leads to the further complication like that of red degeneration and with the combo of pregnancy. So that may be the same which can be present. And sometimes it may happen that there is ovary with that of cyst. What is cyst? It is the collection of fluid in the sac. It's called as cyst. And what it leads to? It leads to the torsion of the ovaries and mind it, and along with the pregnancy. See, so uterus, it is the uterus, it is already with pregnant lady, so the size is increasing along with that of ovaries having some pathology. Which pathology? It is having cyst. What is the meaning of cyst? It is the collection of the fluid in the sac, like a balloon, what we see in the rangoli. That is the with the water inside of it. So that is called as a cyst. And what is torsion? So whatever the location of ovary, it is but obvious. It is in the right side lower region pain. It is going to be there. It is pain. It is in the lower abdomen, and definitely right iliac region or left iliac region, the pain is going to be there because the location of the ovary, it is in the iliac region. So depending upon the side of the ovary, whether it is the right side or whether it is the left side. And as we know that torsion, the patient is not going to coming in your OPD and saying by smiling and says that, oh yes, I'm having nausea and vomiting. See, this is not the same of ovarian torsion with that of the ovarian cyst torsion with that of pregnancy. How we are going to succumb, how the patient is going to the come in the OPD? Torsion, it is the sudden agonizing pain. What is meaning of agonizing? You can't tolerate the patient. Patient says that I'm very going to die. That scene is there. So patient is not a normal. If you see the normal lady in the pregnancy, normal lady comes in your OPD, sit outside of the OPD. When her number comes, she comes inside of you and she says that, yes, I'm having the nausea and vomiting. But while in case of this torsion of ovarian cyst during the pregnancy, so how we are the whatever the relatives are coming with you with that patient, it is in the lying down. Patient is not going to in the walking position. So patient in the lying down comes on the wheelchair and patient is having very agonizing pain. Torsion of, oh, that is the patient can't say that. Oh yes, I'm having the pain. It is not the same with that of torsion of ovarian cyst. It is a very agonizing. I can't bear it. Doctor, just say what is happening with that. That scene we are going to see in torsion of ovarian cyst. So please just when you are going to deal with that of patient, to see how the position of the patient, how the patient comes in front of you, so that we can decide it, whether it is the emergency situation, whether it is some situation because torsion of ovarian cyst or sometimes ectopic pregnancy, ruptured ectopic pregnancy. These are not the same that patient you can talk with the patient lightly. Okay, come, say, okay, what is your name? Not that the same. It is very emergency situation. You have to take very fast decision, and that decision you have to think about it. And if patient is calm and quiet and comes to you and say that I'm having no stamina, Then you can say that, oh, you can get it and I can give you. Now tell what is your name, what is your address, what is it. This is what we are saying. So what is in short, what I mean to say that torture of occurrences, it is not a calm and cool situation. It is something that is related with that of a severe situation that you have to think about it. And sometimes there is a drug induced nausea and vomiting, sometimes iron or opioid groups of chemicals. So when any patient comes to you, then it is your duty. How can you a patient is not going to tell you that I'm taking this iron tablets and I'm having nausea and vomiting. You even you have taken the science, just see the smell of this iron tablets. That can also lead to the nausea and vomiting. So definitely that's why. It's very so patient is not going to tell you that yes, I'm having taken the iron tablets and I'm having this nausea and vomiting. So it is your duty to ask the patient, okay, whether you take any medication. No patient says, yes, yes, I'm taking the various tablets, whatever the iron tablets, then you should have a logic that it can lead to the next immunity. So this is not a obstetric cause, it is a non-obstetric cause. So what is the core of this, what we are talking till time? What is the core of this? That when you are going to take the history, please give the importance to that of history taking. This history taking is going to help you for differentiate between the different causes, what is the stage behind, what is the pathophysiology which is taking place inside of this. So no, we don't have to just wait and I will do the investigation, then I will do the no. What is history taking observation is most important when dealing all these things. So now next thing is the persistent vomiting late in pregnancy. What is thing which we have seen? It is in the early pregnancy. So see whatever I have explained in this. What is how much it is about some up to the pregnancy up to the 3 months, not more than that. But while whatever the thing what we are seeing over here, it is the lead pregnancy. Lead. What is meaning of lead in pregnancy? Means when the females, pregnant females of amenorrhea more than some 28 or onwards up to the 40 weeks, 29 up to the 40 weeks. So if you are seeing this female in the OPD, the patient came with that of some uh, amenorrhea since 7.5 months or amenorrhea since 8 months, amenorrhea since 8.5 months. Then in that situation, and what says that patient, I'm having, patient says that I'm having nausea and vomiting. So that at that time, you have to think this causes. While in previous one, what we have to remain with the history of amenorrhea for 2 months, history of amenorrhea since 2.5 months, history of amenorrhea since 3 months, history of amenorrhea since 3.5 months, then we can think this causes related with it. Right? So if the nausea and vomiting that is led in pregnancy, so what are the causes is it is the acute fatty liver of pregnancy. Okay, so acute fatty liver of pregnancy can lead to execution, then pregnancy-induced hypertension. Pregnancy-induced hypertension, severe preeclampsia, that and imminent eclampsia. What is mean? Pregnancy-induced hypertension. So simple thing, what is going to be there? But of this, BP is going to be more. Basic things. That is, the female is pregnant along with the BP is increased. How much it is increased? It is more than 140 by 90. So don't say that the patient is having some BP that is up to sometimes related with that of 120, 128, 130. Just don't contact 130 by some 80, 80, 80, 82, 84. So it is not a hypertension. What is hypertension? When BP is more than 140 by 90, then it is called as hypertension. So what this is the importance of the clinical examination during what you do it. So that in case of along with that of there is a proteinuria. proteinuria, and there is along with that of edema. Now you know that basic what will happen that when the BP it is increased, why there is a proteinuria and why there is edema. Simple logic. Now you have seen the example of what is the proteinuria, why there is a proteinuria, and why there is edema. We know that the protein, from where it is whatever the kidney, what is the function of kidney? It's like a filter, and whatever the waste products from the body, it is thrown out. And whatever the protein is required everywhere in the body. It is for the consumption, everywhere consumption. What we do it, that is every day the cells are going here and here at that time. So for construction purpose, what we require, the protein is required. And that protein, it is, should not be thrown outside of the body. And what they say that in kidney, how it is, kidney, it's like this filter. And what if the BP it is normal by 120 by 80? So simple, that is, it is not, the protein is having some big structure wise. So it is normal, it is not thrown outside it. But when the BP it is increased by 140 by 90, so but of this simple logic we can use it. So it has to be thrown from the filter, and it leads to the proteinuria, which is not normally present. And simple, whatever the capillaries due to the increased pressure, that is what you know the pathophysiology of the edema. Simple capillaries, and from normal, if BP is 120 by 80, if the cell required something specific, uh, whatever the requirement. So in that normal BP, only the normal, whatever the blood which goes outside, whatever the exchange which takes place. But in case of this one, increased BP, the require whatever the fluid, it is more than the normal required, and whatever the fluid which is collected into the interstitial space, because it does not go back again into the capillary, as we know that whatever the fluid, it is flow from the higher pressure to the lower pressure, and whatever the fluid which is present outside of the capillaries, it is simple, but obvious it is going of less this one, less pressure as compared to that of capillary. So it does not go back again. It remains in between the tissue, in between the two cells, can lead to the edema. Or sometimes if there is a proteinuria, edema, and increase in the BP, that is called as preeclampsia, and preeclampsia plus convulsion is called as eclampsia. So patient with that of this, if patient is 7.5 months, come with that of swelling on the legs and increase in the BP, so we can think that maybe the cause behind it. And sometimes abruptia placenta. What is abruptia placenta? When the placenta it is attached to the upper uterine segment and it is dislodged from it, is called as abruptia placenta. That is, placenta should not dislodge from its original site till delivery. First, the fetus comes outside, and then afterwards the placenta comes outside. But here, the fetus is inside of the womb, inside of the uterus, and placenta before dislodged from inside. That is called as abruptio placenta. And sometimes there is the other non-obstetric cause of vomiting. If you want to understand what is abruptio placenta, I have given in the introduction lecture where you can see it. For junior batch, I will just have again the revision of this first up to the 10, but afterwards. Now, next, define what is the treatment point of view. So it is the support and the reassurance to the female, because she may think that, oh, I may suffer from any complaint. So at that time, the psychological support and the reassurance is more important then avoidance of triggering foods and odors. Sometimes it may happen that females while cooking, she does not like the smell, and that sometimes some foods are having allergy. It's simple. Just avoid it. No any tension about it. Just avoid it and take frequent small meals. What is you can advise? Just have this meal. If a patient is having the meal for 2 times, so how can you take small quantity at 4 times a day? That is, previously she's having the lunch at 1 o'clock and the dinner at 8 o'clock. So what advice you can take at 10 o'clock, small food diet, then again 1 o'clock o'clock, then again comes out at 4 or 5 o'clock, then again at 8 o'clock. So you can divide the whatever the meal into the small portion. Okay? And whatever they eating dry toast or crackers before the rising, that can be, we can advise it. And sometimes it does not handle by this, the last option that what we have to think about the medication. And if still does not patient is not able to manage at the OPD level, then what we have to do, manage at the IPD level. So what we have to do is admission if not responding or not tolerating oral medications or fluids. The patient comes to that patient, I can't tolerate water also. Just when I take the water, it immediately vomited out. Or when I take the medication, it immediately vomited out at that same. You can't get over that scenario. We have to admit the patient in the IPD. And if this is the same where there is a hyperemesis gravidarum, if I see the meaning, just word, what is meaning of hyper? Something more. What is meaning of emesis? Emetics, that is vomiting. And what is meaning of gravidarum? During the pregnancy. So, excess vomiting during pregnancy. Simple. From the word we can understand it. What is meaning of hyperemesis gravidarum? So, same, just say in that scenario. Say definition, what is it? It is a debilitating and potentially life-threatening pregnancy problem marked by a rapid weight loss. Yes, if this scenario it is there is a water electrolyte imbalance. Whatever the cells are doing their function, there is a specific electrolyte balance to be there because whatever this from the cell sodium goes out, potassium comes in, and then action potential develops, and from that cell all that will take place. And if there is a problem with this electrolyte, the cell is not going to do the function, we know that. Cell unites together to form the tissue, tissue unites together to form the organ, organ unites together to form the system, and system unites together to form the body, human body. And if cell is functioning properly, tissue is functioning properly, tissue is functioning properly, organ is functioning properly, organ is functioning properly, system is functioning properly, system is functioning properly. If system is functioning properly, human body is functioning properly. And if there is a problem with the cell, and what is the basic requirement of cell? Whatever the balance, electrolyte balance should be proper in that. Because action potential, it is at the cell level. So if there is a continuously vomiting, if continuously vomiting is there, what it leads to? This vomiting, it leads to electrolyte imbalance, and cell is get problematic, tissue is getting problematic, organ is getting problematic, and ultimately the whole system gets collapsed. It can lead to that of and very damaging situation, threatening situation during the pregnancy or not for the mother, but for the fetus also. There is a malnutrition and whatever the growth of the fetus is not taking place properly, and sometimes there is a severe vomiting with potential adverse consequences for the newborns. So there are many problems with the newborn. So that's what we have to think about it, why we are giving this seriousness to that situation. See in this diagram what we are seeing that this is the right stage which is entering because she is not able to become orally anything. So she is admitted and she is pregnant lady. Then incidence-wise, so how much percentage-wise? So it is the most severe manifestation of the spectrum of nausea and vomiting of pregnancy. So about it's complicates 0.3% of all pregnancy. So if you have 100% of pregnancy, out of that, some 0.3 to 2%, two females are going to suffer from this. And it is typically occurs in first trimester and trimester-wise. And vomiting with, and what is important, blood loss is there. Mind it is going opposite to that of normal progress. We say that if the female of some weight 54 kg, and if she becomes pregnant, her weight up to the last trimester up to the delivery. Her weight from 54 plus 11 kg. So how much it is? 54 plus 11, it is about 64 to 65 kg. That is normal. It has to be taken. This is a normal thing. But what you have seen over here, vomiting with weight loss instead of 54, if that at the age, some she's having some initial increase in the weight about some 54, 55, 56, and after it starts, it drops down. That is, it's coming again 44.5, then sometimes it's 45, 45.5. So that is something wrong thing over here. So it is a weight loss. How much? It is 5% of the pregnant weight. So that is the wrong thing. Then what are the complications? Yes, it leads to the complications. Then which complications? It is the debilitating fatigue. Debilitating means you get exhausted, fatigue, exhausted, and inability to work or take care of their families. So what we see in that if she is doing the job, she is not able to go for the office level or not able to do the job, or if she is doing the housewife. So normally she is wake up early in the morning, do all the house duties. Okay, what is Anjali? Any problem? Anjali? Yes, you can speak Anjali. If you don't understand, let me know. Anjali?
मैम बराबर आवाज नहीं आ रही आपकी।
ओके फाइन, अभी आ रही है बेटा? हेलो?
मैम बीच बीच में अटक रही है, कुछ भी नहीं समझ रहा।
बीच में अटक रही है। नाउ are you able to hear me now?
यस मैम।
Okay, fine. I will try this. Fine. Okay. Some debilitating fatigue, inability to work or take care of their families, and means is not able to do the like the day-to-day activities. Find that like the so the means inability to work or take any care of their families. So she is not able to cook properly, she is not able to do the other functions. Just mutate means okay, fine. If you don't have any savings fine. Then sometimes malnutrition and the dehydration. What is dehydration? The skin becomes not toned. It easily gets pinch of it. So that may be the scenario. Or sometimes frequent vomiting of blood or bile is also. See what is seen, how much severe it is. Then esophageal rupture. It may lead to this, or sometimes gastritis, or sometimes esophagitis, and sometimes retinal hemorrhage, that is hemorrhage into the retina, or vernix encephalopathy, that is related with the problem with the CNS. And sometimes it leads to the problem with that of psychology, that I'm not able to give the fulfillment of the family requirement. So she may go into the depression or anxiety and some social isolation. She don't want to go for the parties, she don't want to go for the family function, she don't want to go for the outside, want to remain alone. So that may be the same. You see, these are the complications which can take place, or sometimes there is a DVT. What is DVT? That is deep vein thrombosis. DVT, that is deep vein thrombosis. That's what we have to see is fine. Okay, just maternal complications. I just have this little bit of short revision of what we have learned today. We have seen the whatever the causes of causes of national vomiting in early pregnancy, non-obstetric cause. Again, there is maybe appendicitis, cholecystitis, or pancreatitis, septic ulcer, gastroenteritis, intestinal infection, chronic infection with Helicobacter pylori. So in that stage, what we have to observe the other signs of this. Then we have seen about the whatever the causes, other causes is that maybe thyrotoxicity, that is eye or pyelonephritis, or sometimes tumors are there, or sometimes infectious fever or brain degeneration of fibroid. And the torsion, I have explained that the patient comes with that of lying down position because there is a severe agonizing pain which is present during the pregnancy, or something done in this. In that, what you have to ask for the any history of any tablet patient taking of persistent vomiting late in pregnancy. To see whether there is a preeclampsia, that is proteinuria, increase in the BP, proteinuria, that is for this we have to give the urine sample. Then we understand proteinuria. Then edema is there, that we have to check the examination what we have to do is. And in eclampsia, patient does not come normal, patient comes with that of convention. Then give the assurance support, initially give the medication, then if not on OPD level, then admit it, do it on the IPD level. And if excessive vomiting, then the patient is having the blood loss is there. So that's what we have to observe it, do it properly, incidence wise, it is out of 100, 2%, and characteristically present with that of 5% blood loss or more than 5%. And it leads to the complication that patient is having debilitating fatigue, some malnutrition, some dehydration. Sometimes there is a vomiting of blood or bile, or sometimes there is a esophageal reflux. She is that, and she is depressed. She does not want to do the work related with depression, anxiety, and social isolation, and DDT. DDT stands for deep red thrombosis. This is the insert what is what we have started. That is how you are going to approach clinically and whatever the causes and the symptoms of related with that of starting of hyperemesis gravidarum. Write the notes and send it on personal number so that I can make the attendance. And if you have any query, please let me know. I can explain it. Fine. So just have the and which questions we are going to ask you. Just clear that which questions are you going to ask for the different causes that you have to explain it and note the causes specifically. Fine. Okay. Thank you very much. And give your attendance and again notes are important. You have to write the notes.